Good evening. Good evening, and thank you so much for joining us. My name is Donna Winowski, and I'm the president of the Pericarditis Alliance. I am also a pericarditis patient. On behalf of the Pericarditis Alliance, we are so pleased to bring this special question and answer program to you. The Pericarditis Alliance is a nonprofit organization dedicated to the proper diagnosis, management, and treatment of pericardial disease. Tonight, you'll learn about pericarditis from Dr. Alan Lewis of the Mayo Clinic and have your pericarditis questions answered by Dr. Klein from the Cleveland Clinic, Dr. Lewis of the Mayo Clinic, Dr. Amazio from University Hospital, Santa Maria della Misericordia, Dr. Al Reyes from Detroit Medical Center, and Dr. Lewinter of University of Vermont Medical Center, Emeritus. My fellow board member and pericarditis patient, Rachel Freeberg, will join me in moderating questions. Thank you to everyone for submitting questions in advance. We'll do our very best to answer as many questions as possible. At the end of our program, we will show the names of our presenters and their locations again, as well as our website and contact information. Our web address is pericarditisalliance.org, and on our website, you'll find biographies of all of the doctors that are presenting this evening. They are board members, as well as links to helpful articles and information about pericarditis. We also have links to two of the centers of excellence for pericarditis, the Cleveland Clinic and the Mayo Clinic. Lastly, we'll be recording this presentation this evening and we'll post it to our website as soon as possible. To begin, I am so pleased to introduce Dr. Lewis, who will share with us what is pericarditis. Dr. Lewis.
Thank you very much, Donna, for the opportunity to really set the stage for this discussion. We're going to be going through in a lot more detail about pericarditis when we get to the question and answer session. So my initial few slides is a simplistic overview of what is pericarditis. So as we all know, the pericardium is a thin membrane overlying the heart. It has a couple of different layers, and there are various diseases that can affect this thin lining outside the heart. The diseases that can affect this include inflammation, which is the inflammatory pericarditis that a number of people suffer from, as well as a thickening, hardening, or leathering of the pericardium, which restricts the heart function, called constrictive pericarditis. The spectrum of inflammatory pericarditis is quite broad. The majority of patients will experience a single episode of pericarditis. This is usually self-limited and resolves by itself, and sometimes people may not even know that they had an episode of pericarditis. Unfortunately, a proportion of patients have disease that persists and recurs and is defined by various different names according to how long they last for and whether they're there continuously or intermittently. And these may be given the names incessant pericarditis, recurrent pericarditis, chronic pericarditis. And all these together may be classified in a spectrum called complicated pericarditis. Pericarditis can also be inflamed to the point that it restricts heart function, called transient inflammatory pericarditis, which is slightly different to the restriction caused by fibrous thickening of the pericardium or scarring causing restriction of heart function, called fibrotic constrictive pericarditis. In the assessment of pericarditis, it's really important that we as physicians take a careful history, that we look for the typical features as well as the unusual features to be able to make the right diagnosis. Because yes, pericarditis occurs, but it often also is interspersed with episodes of chest pain that may not necessarily be pericardial related. And being able to tease out these two is really important in helping define the right treatment for you. Examination is important. We look at laboratory tests, looking particularly for inflammation as is measured by ESR and CRP, which are really markers of inflammation. We may choose to do an echocardiogram looking for a pericardial effusion or evidence of constrictive pericarditis. MRI is also a very useful test in which we look for lighting up of the pericardium called late gadolinium enhancement. We may be able to look for swelling in the pericardium called pericardial edema, and it's really important for us to distinguish normal fat from these findings there. The treatment algorithm for patients with inflammatory pericarditis, as defined by the current 2015 European Society of Cardiology guidelines, really recognize a stepwise approach to treatment. We would often start with a nonsteroidal anti-inflammatory and aspirin, together with colchicine and exercise restriction. And exercise restriction during a phase of acute inflammation is really quite important here. In those patients that don't get relief from this, we may choose to progress to corticosteroids and colchicine. We may try combinations of steroid, nonsteroidal anti-inflammatories, and colchicine. We may try immunosuppression with IL-1 inhibition, azathioprine or IVIG. And last but not least, for those patients that continue to have symptoms despite treatment, or those people who desire to be off treatment but cannot get off treatment, we would consider radical surgical pericardectomy. This treatment paradigm really is ever evolving, and this is what is cited by current literature in the 2015 guidelines. But often cases can be made to push immunosuppression before corticosteroid use or in place of corticosteroid use, and some individuals may consider immunosuppression alongside pericardectomy. And so really there is a bit of an art to the treatment of pericarditis, and you can see that amongst our expert panel here. But really, this is an ever-evolving field. Thank you very much for that.
Thank you, Dr. Lewis. All right, I'm going to start my questions with diagnosis and symptoms. And my first question is for Dr. Klein. So Dr. Klein, how is pericarditis diagnosed? What are the symptoms? And why is the range of symptoms so wide? You've said you see a significant number of patients that don't actually have pericarditis. What do they have?
Okay, thanks, Rachel. A very good question. As Dr. Lewis mentioned, in terms of the criteria to diagnose acute pericarditis, we use the ESC criteria. So you need 2 of 4 clinical criteria. So the first one is pleuritic chest pain. When you have chest pain, you may take a deep breath, goes through your left shoulder. Often you see a pericardial effusion, new or worsening pericardial effusion. The physician may hear a rubbing sound. And the last thing is the EKG almost looks like a heart attack. So 2 of those 4 criteria would be to diagnose it. And objectively, you look at inflammatory markers such as CRP or SED rate, and MRI would be a very important one. I should mention that MRI is increasingly being used, especially for the complicated cases. But clinical criteria can be very difficult, especially you have to take a good history because often they may not have pericarditis, especially in the COVID era and the COVID vaccine era. Patients come with different complaints, so you really have to tease that out. In a recent study, we estimated that 30% of the people coming to a tertiary care center, like Cleveland Clinic, don't have pericarditis. They have atypical chest pain. And what would be the differential cause? So often it could be musculoskeletal, it could be GI, and it could be even non-cardiac. So it's very important to tease that out. Autoimmune patients are very difficult to treat because they have different rheumatic complaints as well. So it's not such an easy diagnosis, but we use the clinical criteria to diagnose.
Thank you. Dr. Winter, this question is for you. What is the most common cause of pericarditis? Are there autoimmune conditions that may cause pericarditis?
Right. Well, the most common cause of pericarditis we term idiopathic. And idiopathic means we don't know. But that doesn't sound very smart. But if we use a long word like idiopathic, it sounds like we're a lot smarter. And so what do we mean by idiopathic? Well, after the sort of evaluation that's been described with stuff like the blood work, history, physical exam, chest x-ray, echocardiogram, MRI, if there's nothing to point to some specific cause, for example, a bacterial infection, an autoimmune disease, we call it idiopathic. In fact, most of these cases are almost certainly due to a viral infection. We don't chase down the virus because it doesn't change treatment, and that gets expensive. So when you hear the term idiopathic, it really means we're saying this is probably a virus. When we're talking about recurrent idiopathic pericarditis, however, this is a form of the disease which has morphed into a different mechanism, and the mechanism is activation of what's called the inflammasome, which produces what are called inflammatory cytokines. And these have names, many of these are named interleukins. The one that seems to be responsible for recurrent idiopathic pericarditis is interleukin-1. And we now have, as I'm sure most of you know, specific therapies that are directed toward inhibiting interleukin-1. So the other part of the question was autoimmune disease. Almost any autoimmune disease can cause pericarditis. Autoimmune diseases differ from the recurrent pericarditis with the inflammasome because in autoimmune diseases, you have antibodies abnormally produced against your own tissues. The problem with the inflammasome with recurrent pericarditis is called an autoinflammatory disease, so that's different. But at any rate, almost any autoimmune disease can cause pericarditis. Most commonly, this is systemic lupus, and secondly, rheumatoid arthritis.
Thank you. Dr. Alrace, if you know the cause of pericarditis, is there a better outcome or chance of a cure?
It's a very good question. And part of my voice. Definitely, if you have a reason for pericarditis, which can be one of the manifestation of other autoimmune diseases, such as lupus or rheumatoid arthritis or mixed connective tissue diseases, targeting that systemic problem sometimes, and most times, in most cases, it does cause resolution of the pericarditis itself. As Dr. Lewinter mentioned, unfortunately, or for some reason, the majority of the reasons for pericarditis is idiopathic or we don't know. So the portion that the question is focused on is when we know the reason, is this better prognosis? I mean, by prognosis, is a better result or chances of this pericarditis to be resolved? The answer is yes. But as we know also, when we have a pericarditis as a manifestation of the systemic disease, every time you have a flare-up of that disease, whether it's lupus or other diseases, that means there is a flare-up of the pericarditis itself. Now, if we target the systemic disease itself and separately by itself will cause resolution or help resolution of the symptoms of the pericarditis indeed. But in some cases, there's some residual, and I work with Dr. Klein in research for many years, there's some residual cases of people have control over their lupus, but pericarditis took a different course by itself. That is activation, as mentioned by Dr. Lewinter, of the cytokines, specifically in the pericardium, which makes specific treatment for pericarditis in these cases is favorable.
And thank you. Okay, this question is for Dr. Lewis. Is there anything that should be done prior to a cardiac procedure to minimize the risk of getting pericarditis? Is there any surgical patient that is most at risk of getting pericarditis?
Thank you very much for that question, Rachel. So, yes, the goal really here is to prevent pericarditis in the first place. And work from my colleague, Dr. Amazio, that's here published a few years ago now, shows that the use of colchicine started 2 or 3 days before an operation can prevent pericarditis. We usually give doses of pericarditis that are similar to the doses of pericarditis that we give to treat an acute flare, and we treat patients for 1 month in order to prevent the likelihood of postoperative pericarditis. Interestingly, you need to treat about 10 patients with colchicine in order to prevent 1 episode of recurrent pericarditis. So that really is not a lot of people to treat with colchicine in order to prevent pericarditis. And really, we probably should be using it a lot more than we do in clinical practice. In answer to the second part of your question, is there a particular group of patients that's at risk? I think the patients most at risk of getting recurrent pericarditis are those people that already have recurrent pericarditis. And so if you have a background history of recurrent pericarditis and you're going to have cardiac surgery, you're probably a patient that would benefit from having radical pericardectomy at the time of your cardiac surgery. And so that's something I would definitely raise with your surgeon, to have a radical pericardectomy or consider having a radical pericardectomy at the time of your surgery.
All right, thank you. Okay, this last question for this segment is for Dr. Amazio. Dr. Amazio, what are the long-term effects of recurrent pericarditis? Can it lead to heart failure or other complications? And what is constrictive pericarditis?
Thank you very much for your question, Rachel. The most feared complication of in patients with recurrent pericarditis is the development of constrictive pericarditis that can be considered the chronic phase of the disease, generally with thickening of the pericardium in about 80% of cases. We know that the risk of developing constriction is not related to the number of recurrences. For instance, we know that this risk is negligible in patients with the idiopathic recurrent pericarditis, but the risk is essentially related to the cause of pericarditis. So we know that the risk is relatively high for patients with bacterial pericarditis, especially tuberculous pericarditis. The risk is around 20 to 30%. Is intermediate in those with systemic inflammatory disease or a post-pericardiotomy syndrome, and is quite low in patients with viral pericarditis. On the contrary, we know that for patients with incessant pericarditis, that is patient without remission, but persistent symptoms that were presented before by Dr. Lewis, the development of constrictive pericarditis is possible even in few months. And so this is a high-risk condition that requires special attention.
Thank you.
Great, thank you. Thanks, Rachel. I think I'll start on some questions. And we have been watching, there's been a number of questions that are coming up in the Q&A, and they're very patient specific. And I'm sorry, we can't address specific questions today, but a number of the general topics will be addressed in the presentation. So thank you. We've turned off the Q&A for now, but for some of the more general questions, we'll be able to answer them at another time. So Dr. Klein, my first question is for you, and my section will talk a little bit more about treatment options. So we heard about this at the beginning, but maybe you could elaborate a little bit on how is pericarditis treated, what is recurrent pericarditis, and how is it treated, and are there side effects to consider for early treatment options such as NSAIDs?
Thanks, Donna. So these are all good questions. So once again, what's current is the ESC guidelines, and they have a stepwise approach. As Dr. Lewis mentioned, that when you have acute pericarditis, the first episode, you're often treated with a combination of NSAID, something like ibuprofen, and you add colchicine, and you tell the patient to limit their exercise when they're active. How long do you treat for the first episode? Colchicine up to 3 months, and I would say for NSAIDs, 2 to 4 weeks would be the usual treatment. Most of these patients resolve without seeing a cardiologist. However, after the treatment, the first episode, it comes back after 4 to 6 weeks, often when you taper the medicines, and that's called recurrent pericarditis. So the treatment's the same except for longer. So it's the same meds, NSAIDs, colchicine, and exercise restriction, but much longer, colchicine up to 6 months or even longer. Then you have what we call complicated pericarditis. We alluded to that already. These are patients with multiple recurrences, sometimes colchicine resistant, steroid dependent, constriction, tamponade would be the complicated group. In terms of side effects, definitely you want to balance how severe the pericarditis is with the potential side effects. So let's take NSAIDs. A common thing would they have a GI upset. You're giving a large dose of ibuprofen. So often we recommend H2 blocker, something like a meprazole or something like that when you take that. Colchicine, diarrhea would be, GI symptoms would be common. Sometimes they get neuropathy. Sometimes you get a low white blood cell count. And there's a further question a little later on about steroids, and they have plenty of side effects as well. We're going to get into the biologics, and I'll let the other speakers answer any side effects with biologics. But at standard therapy, and I should mention, as we'll hear a little bit later, there is a paradigm shift how we treat the complicated recurrent pericarditis, perhaps avoiding steroids. Thank you.
Great, thank you. Dr. Lewinter, the next question is for you, please. Talk to us about biologic medications. When you're on a biologic, how long does it take to work? Will a patient be taking them for the rest of their life? And why would someone take biologics?
It's a big question. So the strict definition of a biologic medication is one that is made within a living cell. Although these days, some of these can actually be manufactured without having a living cell. Most of these drugs are proteins. They can be naturally occurring proteins like an antibody or an engineered, more and more an engineered protein type molecule. And these are designed to interact with a very specific cell receptor or molecule. So it's very focused type of treatment. They are almost invariably given parenterally, meaning by injection under the skin or by intravenous infusion. Proteins will be broken down if you take them by mouth. Biologics are now used to treat a wide variety of diseases, various immune-mediated diseases and various cancers. Compared with conventional drugs, biologics, of course, are much more targeted and therefore cause less side effects in general. So, for example, I mentioned interleukin-1 antagonists. These are rilonacept, anakinra. These are drugs I'm sure many people that are attending know about. These are biologics, and the alternative in the past to these had been prednisone, which causes lots and lots of difficult side effects. In general, the IL-1 antagonists have a very good profile in terms of adverse effects. It's not zero, of course, but it's much less of a problem with these drugs. The time it takes for these drugs to work in general is very variable and depends on the disease you're treating. In the case of pericarditis, thankfully, these can work very rapidly, and we've seen patients literally respond within hours. I think that's unusual, but they work quite rapidly and very impressively. How long to take these drugs is a difficult question, which we are learning about. In the case of the Rhapsody trial, which was rilonacept, attempts, typically the drug has been given for 1 to 2 years. And when you stop the drug, often these patients will recur after having a very long period without any difficulties most of the time. So it's hard to decide when to stop. But there are some clues that we can get from magnetic resonance imaging in particular, which allows us to quantify pericardial inflammation. And Dr. Klein really has been the pioneer in this area, so we owe him a lot of thanks for that. It looks like that using an MRI to document that inflammation is either gone or largely resolved will be a good way to decide when to stop these drugs, but that still needs a lot more research to pin it down. At present, we know these drugs in general have to be given for a fairly long period of time, but in an individual case, it's very difficult to say what to do. And hopefully, again, MRI will give us good clues as to when to stop.
Okay, thank you. The next question for Dr. Alraiz, please. And the question is, can you still get a flare while taking biologics? And maybe you could touch on what a flare means too.
That's
Thank
a very
you.
good question. And oftentimes we get it from the patient who get flare on biologics. So as Dr. Lawenter mentioned and Dr. Klein published before, there is a recurrence or what we call a flare-up of these patients, meaning there is an event where pain is controlled, there is symptoms is no shortness of breath, activity and tolerance to activity is perfect, and all of a sudden the patient report, oh my God, I'm having another chest pain attack, I'm having other symptoms when I'm taking the medication as instructed. So in these cases, how often does it happen? The good news, it doesn't happen that often while you are taking the biologics. However, if you are starting with the standard of care that Dr. Imazio published before, which is the colchicine and NSAIDs, the longer the period of time is recommended for 30 days. If you want to stretch it for more, is fine, depending on what phase of the therapy and what type of pericarditis is the patient experiencing. Now, if you are talking about somebody who's having recurrent pericarditis and kind of receiving the ultimate therapy for recurrent pericarditis, yes, there is a small percentage of patients, maybe in the 5 to 10%, where they're going to continue to have flare up or recurrence of symptoms. The severity might be not as bad. The duration of that flare wouldn't be as bad as the acute phase, or we call it the initial attack. But definitely it does happen, and in these cases, definitely another agent would be recommended to help with that flare.
Thank you. Dr. Lewis, I'm going to ask you the next question. And this one is referring to anakinra. So I know we've talked a bit about rilonacept, but the question is related to anakinra, I think, because it's been out there a little bit longer. So the patient is asking about weaning off. Are you ever able to successfully wean off anakinra? How do you taper? So this particular person, and we're kind of looking at this as like maybe a typical scenario. This person has taken anakinra for over 2 years. He or she has had chronic recurrent pericarditis that didn't respond to prednisone, colchicine, and other immunosuppressants. But anakinra was a game changer. I tried to wean off, but it keeps coming back.
Thanks for the question, Donna. And if you don't mind, I'm going to broaden your question slightly because I saw some questions in the chat asking exactly the same question with rilonacept. So I'm going to try and cover both here with that question. So in terms of success in weaning off anakinra, this work was really published in the IRAP registry by myself, Dr. Imazio, and Dr. Klein. We all contributed patients to this registry, and it really looked at what happens after we reach the end of anakinra therapy. There was quite a lot of practice variation across different sites, but in those patients that got at least 3 months worth of anakinra, we could see that the recurrence rates were even up to 50%, meaning 1 in 2 patients that got anakinra may have had a recurrence of pericarditis at follow-up after discontinuation of anakinra. Unfortunately, the data is no different with rilonacept or Arcalyst. And if we look at the published data on rilonacept in this patient population, when we look at their pivotal Rhapsody study, at the end of follow-up, after 18 months worth of therapy, 3/4 of patients had recurrent pericarditis. So, this tells me that both agents have comparable efficacy and comparable difficulties with taking patients off treatment, with the likelihood, I don't think one is any better than the other. And I think that the likelihood of people getting recurrent pericarditis is about 50% or so. We don't have any data as to what to do with rilonacept in the longer term and if tapering is helpful or not. But in the IRAP registry, the suggestions were that longer durations of anakinra was helpful in reducing recurrence rate, and we compared less than 3 months to more than 3 months in that study, so relatively short durations of therapy. And then we looked at tapering of these agents, and we found that tapers of longer than 3 months was beneficial in preventing recurrence. And really, we don't have any data for rilonacept because rilonacept is a drug that's licensed to be stopped at the end of therapy without any tapering. And so I cannot comment on tapering with rilonacept here. I've had a number of patients that have had difficulty coming off treatment at the end of their treatment. And really, that leaves us in a scenario where we really have two options. One option is to say, well, that drug works for me. I'm going to retrial drug and hope that I can reattempt to come off drug at a later date. So that's one of the options. I've had some of my patients tell me that I'm happy with the way I am on one of these IL-1 receptor blockers, and I would like to continue these therapies potentially indefinitely. And then I have a third group of patients who cannot foresee taking these drugs for the remainder of their lives. And so they will speak with me about surgical pericardectomy. And I think that is another viable option that they're going to be discussing here in a moment. I think the importance with pericardectomy is it really needs to be done by an expert surgeon, someone who does these for recurrent pericarditis, not for constrictive pericarditis. The reason I say this is it's of utmost importance that we take off the pericardium in its entirety, because the traditional complete pericardectomy takes off about half the pericardium, which sort of fixes constrictive pericarditis. But if you leave half the pericardium behind in those patients with recurrent pericarditis, it doesn't necessarily address the question there. And so those are sort of the three options that I see at this time point when we're not able to get people off treatment.
Okay, thank you. Dr. Amazio, here's a question again on biologics, and it's a more specific question saying, are biologics safe during pregnancy, and what treatment options are available during pregnancy?
Thank you very much for this question. This is a really challenging situation. We have a very limited experience with the use of biologic agent during pregnancy. They are formally contraindicated in this condition. And so the main problem for us, for clinician, is how to treat a patient during pregnancy. So we know that non-steroidal anti-inflammatory drugs can be used in the first part of pregnancy till week 20. They can be used, but after, in the last part of pregnancy, probably low-dose corticosteroids are a good option. So nowadays, although there are also case report with experiences of a pregnant woman treated with a biological agent with no consequences, these drugs are contraindicated, and we should consider conventional therapy with the non-steroidal anti-inflammatory drugs and low-dose corticosteroids.
Okay, thank you. Dr. Klein, you alluded to this question coming up earlier. Steroids, are steroids safe to take long-term? Why or why not?
Well, I should say that of all anti-inflammatory agents, probably steroids are probably the most potent. That's a good thing, but the bad thing, you have trouble coming off and you have a lot of side effects. And as I alluded to, there is a paradigm shift in the future for these very difficult cases, maybe to avoid steroids because of the potential side effects. Just to list a few things. First of all, you worry about your bones, osteopenia, osteoporosis. So you may need like a bone scan. You may need to take calcium, vitamin D, and other types of medicines. Weight gain and fluid retention is a big issue. I should mention Dr. Mazzi showed recommend to start lower dose steroids, 0.5 milligram per kilogram, roughly 40 milligrams, 35 milligrams in a usual size person with a slow taper. People get mood swings. Either they're euphoric or they're very angry. Depends on the mood. You get adrenal insufficiency. The adrenals are suppressed with exogenous steroids. People get cataracts, to name a few. We are doing a project looking at the patients that have been on steroids for a while versus other standard of care, and we're listing all that side effects. So definitely steroids should be used in certain indications, but they have their difficulties, and that's why perhaps biologics may substitute. And Dr. Lewis mentioned some of the issues of getting off the biologics is another issue. But you want to give patients the lowest possible doses for some of these medicines, and with less side effects.
Thank you. Dr. Lewinter, this question is for a patient that suffers from recurrent pericarditis. Is it best to have a pericardectomy early if it's getting difficult to treat? Maybe you could just touch a little bit on what they do. What is a pericardectomy, and what's recovery like if you have a pericardectomy?
Right. So
We heard a
I'll
little
start
bit
with-
about it, but
Yeah, I'll start with the procedure itself.
thank you.
We've alluded to this a little bit before, but for the record, a pericardiectomy is simply removal of the pericardium. The pericardium serves no significant useful function, although it does have some functions. So its removal, so far as we know, does not have any serious long-term health effects. But it's, even though it's a low-risk procedure in most patients with recurrent idiopathic pericarditis, and most patients with recurrent pericarditis have idiopathic pericarditis, and that's because the procedure, the pericardium itself is not thickened, it's not fibrotic, so it's pretty easy to remove. In contrast, this is a much more difficult procedure in patients that have constrictive pericarditis, with long-standing fibrosis, often calcification. It's a very, very different procedure in those patients. For those, though, again, with recurrent pericarditis, it is a low-risk procedure, does not require cardiopulmonary bypass, but it shouldn't be minimized. It still is a major procedure which requires opening the chest. There is a significant recovery time. It's not terribly long, but probably on the order of a month or two for most patients, and certainly some complications can occur. As has been mentioned, it's very important, if you're doing the procedure for recurrent pericarditis, to remove as much of the pericardium as possible. And relatively few surgeons really are concerned with this and do this well. So it's very important to select your surgeon in this area. In addition, no matter how much you remove, it's not possible to remove all of the pericardium. And in particular, there's a part of the pericardium that's right on the surface of the heart. It's called the visceral pericardium, and you can't get that off. It's connected to the surface of the heart, so that's going to be left. So this leaves the possibility for continuing recurrent pericarditis even after the surgery. And while the surgery appears to work well in many patients, there's no real guarantee that you're going to have a good result. So the question of timing is a tricky one. I think most cardiologists who treat patients with pericarditis feel like we ought to go through the various medications we have in our arsenal, especially the IL-1 antagonists, before offering pericardiectomy. But if you're running into problems, even with the most useful and beneficial drugs that we have, that's certainly the time to consider this. There may be some patients in whom we should think about it earlier. For example, patients who feel like they just can't put up with taking medications and want to have the possibility of not having to take medications. But once again, I want to stress there's no guarantee of results. So it's possible in that circumstance, you might have a patient who's gone through all of this and you're back to square one. So this is a kind of a difficult question as to when to offer pericardiectomy. I suspect if you polled everyone here, you'd get somewhat very variable answers on that question.
Dr. Lewinter, I'm not sure we touched on what's idiopathic pericarditis and constrictive pericarditis. Will you touch on those quickly before we move to the next question?
Sure. So idiopathic, once again, is pericarditis where after going through a standard kind of evaluation, which has been mentioned previously, again, physical examination, blood work, chest x-ray, MRI, et cetera, we don't identify something specific, for example, like a viral infection, like an autoimmune disease. So that's why we call it idiopathic. And again, we think most of these are viral. What was the second part of that, Donna?
Constrictive. What's constrictive pericarditis?
So constrictive pericarditis, it is what happens when the pericardium restricts, because it's thick and stiff, restricts the ability of the heart to fill. And that causes basically heart failure. Restrictive pericarditis can occur in the setting of idiopathic pericarditis, where you have a very striking immune reaction with marked thickening and edema of the pericardium. And that type of constrictive pericarditis is very amenable to treatment with anti-inflammatory medications. On the other hand, there are cases of constrictive pericarditis which are very chronic, where you have a great amount, again, of scarring and even calcification of the pericardium, that can occur with a variety of diseases. It's rare, however, for it to occur with idiopathic pericarditis, and Dr. Imazio has really provided publications which attest to that. So usually, chronic constrictive pericarditis with a lot of scarring, et cetera, is due to some specific disease. For example, bacterial pericarditis, rheumatoid arthritis is another one.
Okay.
So.
Okay. Thank you. Thank you. I know we're having so many great questions. We're getting a little late on time. It's about 6:15. So I'm going to ask our doctors to help me get through quite a few more questions before 6:30. So next question is also on pericardiectomy. I think I was saying it maybe wrong. For Dr. Alraiz, if someone does have one, will they still need to be on medication after surgery? And are there certain centers that perform the most pericardiectomies?
That's a very good question. As Dr. Lewinter eloquently mentioned, you have to have this done in the surgeon who have done it the most. It's a very delicate surgery. Again, it's done off pump, meaning it doesn't need to have the heart to be arrested and connected to a machine to oxygenate and bring back blood to the heart. It's not, but it's definitely is delicate. I would say at least a center that does 50 of these surgeries a year is considered a center of excellence, and I will definitely make sure the surgeon is familiar with the procedure and will consider an expert. Whether, again, Cleveland Clinic and Mayo Clinic is known to be the most in the US to perform these procedures.
Great, thank you. Dr. Lewis, why do some people experience chest pain without active pericarditis, like their inflammatory markers and their imaging still looks normal? So sometimes patients just don't perfectly hit the markers. Do we educate practitioners to treat pericarditis even if those markers aren't present?
Great question, Donna. So, I think in our lives, we're not used to paying attention to our chest. We're not used to paying attention to various minor sensations that we have, and our brain is designed to ignore those sensations unless it's something significant. When people have pericarditis, suddenly there's a reason to pay attention to your chest. You have something wrong with you, so you pay attention and you focus on this thing that is wrong with you. What happens in that is we also focus on other sensations that we probably ignore because of sensitization of the nerves that make us more aware of these sensations. And so some of the chest pain episodes that we experience when we have recurrent pericarditis are not due to inflammatory pericarditis, but rather these additional sensations that our nerves have become sensitized to. And so that often leads to the 1/3 of patients that Dr. Klein was talking about, in whom we find no evidence of pericarditis, even though they've had a previous episode of pericarditis. And so I think it really falls back to this question. In terms of education, this group definitely does a lot to provide education to physicians. We provide education through conferences. We provide education through grand rounds at our various institutions and at other institutions. And Dr. Amazio is chair of a working group for the European Society of Cardiology on pericardial and myocardial diseases.
Great, thank you. And that leads me right into my next question. Dr. Amazio, what is the working group doing, or what do you do to educate practitioners in Europe?
Well, our activity is very important. The education of practitioners is a key point also to improve the treatment of the disease. And one of the major points are a recommendation regarding the physical activity restriction, because we know that pericarditis is inflammation of pericardial layers. So the friction of pericardial layer increases with the high heart rate, and this is what happens during a physical exercise. So the restriction of physical activity during the active phase of the disease, when the patient has chest pain, is very important to improve symptoms and to reach remission earlier. Current guidelines recommend an arbitrary time limitation for physical activity, up to 3 months for athletes until clinical remission for non-athletes. Probably the future will be to individualize these recommendations. So essentially the physical restriction should be recommended till clinical remission, that is different in different individuals. But probably new guidelines will be used in 2025, and by the European Society of Cardiology, I have the privilege to chair these guidelines on myocarditis and pericarditis, and we will probably address and update these recommendations.
Thank you. Dr. Klein, we touched on MRIs earlier. Does an MRI ever fail to detect pericarditis? And if pericarditis is left untreated, will scarring occur? And is there a higher chance of getting constrictive pericarditis if it's left untreated?
Okay, thanks, Donna. Great question about the role of MRIs. I think I should mention not all MRIs are equal. So in other words, you need a proper technique. There's unfortunately very few places that do perfect MRIs with fat suppression. So you need a good technique for the MRI. Now, MRI is very important in good hands. They can tell you how severe the case is, what the prognosis, how long the therapy, the likelihood of going on biologics, and perhaps when to stop. So very, very powerful tests. And as we heard earlier, pericarditis is a spectrum, so it really depends when you catch the patient. So if you're very active, you're flaring, you're going to pick up swelling or edema and inflammation. And then you see over time, the edema goes away, and then you're left with the inflammation, and that gradually disappears. Untreated with many recurrences, and also Dr. Mazio mentioned, let's say with bacterial infection, even post-cardiac injury. If you don't treat this, you're going to get a lot of recurrences. You're going to get fluid in the heart, and you're going to get complications, and scarring of the pericardium, leading to constrictive pericarditis, where the choice would be often surgery. Now, but there's another concept that we heard about, transient constriction. Roughly 60% of cases that come through Cleveland have an inflammatory component to this constriction. And perhaps we give the college try, we try 3 to 6 months of active anti-inflammatories, including some of the drugs we talked about. And perhaps you don't have to go to surgery. So MRI is a powerful test in good hands. We're looking at reproducibility, different institutions being trained with this, but I shouldn't forget about echo as well and other imaging modalities.
Great, thank you. In interest of time, I am going to turn it over to Rachel to pick up the last section of our questions. Thank you.
Thanks, Jonah. This question is about lifestyle and exercise, and it's for you, Dr. Alrace. What are the restrictions for exercising after the initial diagnosis of a pericarditis or a flare? What exercises do you recommend, and when can a person start playing sports again? And then the last part of that question is, are there any studies that look at exercise and pericarditis? That was Dr. Alrace.
Okay, thank you. Sorry, I lost my camera for some reason. Can you hear me okay? Yeah, as you know, and as we recommended by the guidelines, is during the flare, it's recommended to stay away from any strenuous exercises. What it means is anything that bring the heart rate faster than usual. So any competitive sports, jogging, football, basketball, should be avoided for during the time of the flare. Now, there is some, for example, other sports like yoga, for example, is a type of meditation, as well as does not bring the heart rate up. I think it's okay, and it doesn't affect the heart rate, and I don't think it will exacerbate the flare up. So things kind of sports that where you are within the heart rate, walking within with a slow or brisk walking, I think that's also acceptable during the flare. Outside the flare, again, there is a mixed kind of recommendation, but I think in general, is refraining, especially if somebody had a very close recurrent episodes, is recommended to stay away from strenuous exercises till these episodes are spaced out.
Thank you. I have two follow-up questions. I don't know if I remember anybody saying, what is the maximum heart rate when you're exercising that you guys recommend?
I think there's no good studies. In general, people are very health conscious. They often have a digital watch, a Fitbit or an Apple Watch. So I try to say, keep your heart rate less than 100. You're perhaps on the injury reserve list, like walk your dog. But on the other hand, the downside of lack of exercise is very apparent. So, it's a very fitness culture, and people do get depressed not exercising. So there are some studies that some of our group is doing with exercise on biologics, see if people can exercise on biologics. And also, getting the digital watch type data out and really correlating recurrences with faster heart rate. So a lot of interest with exercise, and it does affect, all of us see professional players that big decisions have to be made with their exercise. But it's a fascinating area, and it's an important area.
Thank you, Dr. Alrace and Dr. Klein. The last set of questions is COVID related. And the first one is for Dr. Amazio. Why are people getting pericarditis after the COVID vaccine? Do vaccines in general trigger pericarditis flares?
Yes, thank you. This is a very important question. We know that vaccine are causes of pericarditis. They can trigger pericarditis, and also COVID vaccine can trigger pericarditis. This is essentially an immune response. I also was a patient, and I get a recurrence of pericarditis following a flu vaccination. So all types of vaccine can cause this pericarditis, and COVID vaccine was an example.
All right, thank you. Next one is for Dr. Klein. Are there statistics on the COVID vaccine or COVID infection related to pericarditis? Are there statistics on the COVID vaccine infection related pericarditis? And is anyone with certain conditions more susceptible to getting vaccine related pericarditis?
There's a lot of papers, Rachel, on COVID related myopericarditis. And as well, there's a lot of papers on the vaccinations, the mRNA vaccinations and pericarditis. And as Dr. Mazzio alluded to, it can definitely cause it. Now, you're much more likely to get cardiac issues from the actual COVID-19. The incidence of getting a myocarditis, pericarditis from the vaccine is extremely low. And it's actually one statistics that's roughly between 2 and 20 per 100,000 people. So it's extremely, extremely low, and much more higher getting a myocarditis from the COVID infection. So in other words, do take the vaccine unless unless the vaccine triggered or the booster triggered a pericarditis. So it usually occurs in young people. Usually 19-year-old men with a lot of testosterone. So that could play some role. And it's usually a couple of days after the second booster when it would occur. It's not life-threatening. It has a non-fulminant course. So in other words, it's more of a benign course with symptom resolution. But a lot more data coming out about this. And we all have examples, our group, of people getting some infection after the vaccine. But I want to encourage people to take the boosters because it's a very, very low incidence.
And thank you. Even if someone has had a current or past episode of pericarditis, should they get the flu or COVID vaccine?
Only if they think that the vaccine, that there's a good temporal cause. You get the vaccine 2-3 days later, you get the pericarditis. Sometimes it's vague, so then that's a shared decision making with the patient. And just to I always mention that we're seeing the group is seeing much more patients with complaints from COVID and the vaccine. So we have to tease out. The clinician really has to tease out is this really related or unrelated?
Thank you. Thanks. Last, I have to skip. I think I kind of squeezed the second to last question about COVID in there, and I'm skipping the very last question about COVID, which I think it was already covered a little bit. So I don't think we're missing much. Dr. Lewis, you are going to do the last question, and it is there ongoing research into pericarditis? Are there any new therapies?
Thanks, Rachel. So yes, there are ongoing trials into pericarditis. I think the most useful website in defining these is to go to clinicaltrials.gov. It's a government website that lists all clinical trials currently available. A number of us on this panel have conflicts of interest related to this. And I need to disclose them, being an investigator on the cardiac therapeutics trial as well as on the Kiniksa resonance trials. But just to go through some of the trials currently listed, I see that there's a trial on there looking at dexamethasone versus non-steroidal anti-inflammatories being run in Israel by our Israeli colleagues. Our Italian colleagues are doing trials on anakinra and cardiac MRI. There's the company that makes rilonacept is doing a national registry of patients with recurrent pericarditis, and a company called Cardiac Therapeutics is investigating the use of cannabidiol in patients with recurrent pericarditis.
Great, thank you. Well, we are at 6:30. Thank you all so much for participating. I would like to invite the doctors, our panelists, to share any final comments before we close. Any final remarks or thoughts?
I can start. First of all, I want to thank the Pericarditis Alliance, Donna, Rachel, and Stelina, and the group for organizing this. So I think the future is very, very bright in this field. It's sort of it's making a renaissance. Now we have the imaging to sort of see the pericarditis, and we are developing, from, as you heard from Alan Lewis, about the new trials on the therapeutics. So I think we're getting this field covered, and the future is bright.
I'd also like to thank the Pericarditis Alliance for organizing this and providing the information to the patients and making them available. I'd like to thank all of you, the patients, for putting in all the questions that all of you have sent in. They've all been excellent questions, asking excellent information, and I hope that this has been helpful to you. And exactly as Dr. Klein said, the future is bright. We are making advances in this field, and we hope that those advances will continue to improve each of your qualities of life.
I would also
I'll go next.
sorry.
Go
I
ahead,
would also
Ramzi.
thank very much the Pericarditis Alliance for organizing these educational events. I also think the future will be brighter, and we are nowadays on the way of a more evidence-based approach on to the management, and a more individualized approach to treatment.
I just wanted to
Like
comment.
point
that,
out that
I just wanted to comment that this is a classic example of a literally a revolution in care for a problem that didn't have such wonderful answers in the past. And I would also encourage our patients to ask lots of questions. I'm always impressed by how smart pericarditis patients get. Maybe that's not a great thing, but in terms of their experiences, but it's really remarkable how much so many of our patients learn about this.
I can see the difference between 10 years ago. We never had any guidelines or alliance that put together, and now we came a long way having this alliance, kind of advocating for patient, number one, and two, kind of streamlined available therapies and new publication research for patients. Thanks for the patients who participated with us today, as well as the panelists. But really, it was a pleasure and a great journey, and definitely the future is brighter.
Thank you all so very much for being with us and for answering these great questions tonight. I'm going to let you all go. Thank you very much. Good night.
Okay, thank you. Bye-bye.